Today we will discuss some other protocols. Diminished ovarian reserve is a predominant risk factor for antagonist cycle where premature LH surge happens quite frequently. Premature ovulation through antagonist suppression is a rare event occurring 0.34% of the antagonist cycle. The patient experiencing ovulation had consistently poor ovarian reserve compared with the controls, as evidenced by higher day 3 FSH level, low interfollicle count, and low anti-Mullerian hormone. Now, what is to be done? If this happens in subsequent cycle, double the dose of antagonist with twice daily dosing morning and evening. But the higher dose than 0.5 milligram, it is inadvisable. It gives a lower pregnancy rate, which has been already noted in the original dose finding studies when higher dose of gangrenics was used. Of course, the subsequent protocol using either conventional agonist luteal suppression or macroflare protocol can alternatively be used. Now, there is a role of LH after stimulation which is commonly known, but there is a paper which suggests LH pre-treatment for younger poor responder actually before stimulation. So it has been suggested that short LH pre-treatment actually before the starting FSH stimulation corrects the oocyte maturational defect which could have been worsened if exposed directly to FSH. It improves oocyte quality, but in terms of quantity, the results are not comparable. It's not good. So it definitely improves the quality. So it is worth trying in young poor responder. The progesterone has got LH suppression effect, and nowadays freeze all policy works well because the vitrification technique has been simplified, become efficient, and all are gaining expertise in vitrification technique. So progesterone's LH suppression effect and freeze all protocols efficacy suggest that progesterone may be used as an alternative to GnRH analog for suppressing premature LH surge under control ovarian hyperstimulation in IVF cycle using freeze all approach. So in this protocol, what is done? The HMG 150 to 225 international unit and medroxyprogesterone 10 milligram per day to be started from period cycle day 3. 150 international unit gonadotropin used for hyper and poor responder and 225 for normal responder. When the criteria for the ovulation triggers are met, the dual trigger in the form of gonapeptide 0.1 milligram plus HCG 1000 unit subcutaneous to be given. During the study, the hormonal measurement showed that the pituitary LH level were suppressed after 5 days of medroxyprogesterone administration. The LH surge block failed if medroxyprogesterone administration was started during mid-follicular phase in women with multiple growing follicle and elevated E2 level. So you cannot start similar to antagonist as if to prevent the LH surge. It has to be started from the day 3 only. In case of failed premature luteinization, suggested that in the presence of high day 3 serum E2 level, medroxyprogesterone acetate served a positive facilitative role in promoting LH induced cyst luteinization. Therefore, the regimen should be used in case with basal E2 level not more than 50 to 70 picogram per ml on day 3. If high, then this might not work. The duration of gonadotropin administration and HMG dose were higher, uh, approximately 400 international unit difference was there in the medroxyprogesterone acetate co-treatment group. Then in short protocol, the stimulation lasted for 1 day more. The high progesterone level in control ovarian hyperstimulation did not increase the risk of congenital malformation compared with the short protocol. So this is a protocol where you can save on antagonist, but you have to freeze all the embryos and little dose of gonadotropin is increased. The stimulation may increase for a day. Another protocol where the CC clomiphene is given in the late follicular phase. In this protocol, day 3 onwards, injection HMG 150 international unit for 5 days fixed and clomiphene 50 mg TDS from 4th day of HMG till trigger. There was no need of any agonist or antagonist uses because clomiphene takes care of LH surge. It has been observed that it reduces the LH surge, it gives better follicles than HMG alone, mean E2 level is higher, the anti-estrogenic property of the clomiphene is masked by HMG. There is no difference in the endometrial thickness and it reduces the requirement of monitoring. So basically this protocol was suggested for IUI, control ovarian stimulation for IUI treatment. But if this is tried in IVF, it can be tried. The another protocol where agonist FSH, agonist recombinant LH protocol, in which the agonist lupride 1 milligram or buserelin 0.5 milligram or decapeptyl 0.1 milligram given for only 3 days. day 2, day 3, and day 4, which will cause agonist flare. The recombinant FSH 225 to be started from cycle day 5, means next day of agonist. Again, add agonist and recombinant LH 150 units. If recombinant LH is not available, you can add 20 units of SCG from cycle day 10. And this is agonist protocol, so trigger is to be given by SCG. In short, in this protocol, the advantage of agonist flare is also taken, but then agonist was stopped for a couple of days to prevent oversuppression, and as soon as the follicle started growing from cycle day 10, maybe for 2 or 3 days, maybe 1, 2 or 3 days, again agonist was added along with the recombinant LH, and which gave better result. The conclusion was the recombinant LH supplementation in GnRH agonist cycle improves implantation and pregnancy rate, probably via improvement in oocyte quality and or uterine receptivity. The young poor responder is another difficult group to treat. So luteal estradiol antagonist protocol has been suggested for them, in which you have to start monitoring on the previous month, document the ovulation or LS surge, 7 days post ovulation or 10 days post urinary LS surge, estradiol 2 mg BD to be started, and it is to be continued till menses. If you want to plan batch the cycle after starting the menses, the estradiol can be continued couple of days more, but not more than 14 days. After 2 days of estradiol in the luteal phase of the previous month, the antagonist 250 microgram subcutaneous to be given for 3 days, which will cause a luteolysis and it will bring down the LH and FSH level, and which will help in synchronization of the follicle and will give a uniform recruitment of the follicle. The stimulation to be started from day 2 with higher dose of HMG, that is 450 to 600 international unit, step down after 10 millimeter of the follicle once the majority follicle reaches 10 millimeter size. Antagonist to be restarted when the criteria are met, that is stimulation day 7 or 13 millimeter lead follicle or E2 more than 300 picogram, and agonist trigger to be used. Basically, in poor responder, there is early rise of LH, which is likely to give asymmetrical follicular growth or the follicles of different FSS sensitivity, giving a poor yield. So, to synchronize them, in the previous month, estradiol plus antagonist was used, and again after stimulation it was restarted. This gives good result in young poor responder. It increases the gonadotropin consumption, but still it gives a good hope for young poor responder. There is another protocol which is a type of soft protocol in which the CC and HMG used unchanged, in which daily clomiphene 100 milligram and 150 international unit of HMG used in a fixed manner till trigger. In this pilot study, the embryo quality was significantly better when using clomiphene citrate in combination with a lower dose of gonadotropin. So they found that if you combine clomiphene with HMG and use till trigger in the same uniform fashion, if the lower dose of gonadotropin like 150, it gives a better embryo quality in soft protocol. There is another soft protocol which is a Cato protocol, in which the clomiphene citrate 50 milligram from day 3 till trigger is used, and HMG is used 150 alternate from day 8, and trigger is Agonist, which is also a good protocol for good soft protocol. There is a lot of confusion between mild and minimal stimulation protocol. Basically, in mild protocol, the target is to retrieve maximum 10 oocytes, in which low dose of gonadotropin plus antagonist is used. Whereas in minimal stimulation protocol, target is to retrieve 1 to 5 oocytes, in which clomiphene 100 milligram from day 3 to day 7, HMG 150 from day 8, the antagonist from day 11, and trigger when more than 2 follicles were more than 17 millimeter. In minimal stimulation protocol, whenever the clomiphene is used in a proper dose, that is 100 milligram, the antagonist can be delayed, as after giving clomiphene, the LH surge before day 12 is unlikely when it is clomiphene is given for day 3 to day 7. So antagonist can be safely started from day 11. It reduces the cost, it reduces the injection burden, and it gives the equal results. In the milder ovarian stimulation, this is another novel protocol which combines the use of clomiphene plus letrozole plus gonadotropin. In this stimulation protocol, 25 milligram per day clomiphene is used from day 3 to continuously till trigger, and 2.5 milligram per day letrozole is used from cycle day 3, but the letrozole is given only for 4 days, whereas clomiphene is continued till the trigger day. Apart from this, gonadotropin 150 hmg is given on alternate day beginning from the cycle day 6. In the original trial, the final oocyte maturation was induced by 0.1 milligram of triptorelin, and they compare with the luteal phase stimulation, but initially they induced with the triptorelin. For the luteal phase stimulation and mild ovarian stimulation protocol with 5000 international unit of SCG. Basically, they were comparing a mild stimulation protocol with LPS, luteal phase stimulation protocol. Additionally, 0.6 gram of ibuprofen was used on the trigger day and on the next day for luteal phase stimulation and mild ovarian stimulation protocol. So they found a good result if they use clomiphene continuously 25 milligram, which would prevent LS surge, letrozole in the initial 4 days, and HMG from cycle day 6 till they meet the criteria of trigger, and agonist trigger was used. Another mild ovarian stimulation protocol with clomiphene citrate, which I use very frequently, in which the clomiphene is started from day 3 to day 7, that is 100 milligram. Recombinant FSH started 150 IU day 5, day 7 and day 9. Patient is called on day 9 and folliculometry is done with the sonography. If the follicles were less than 3, cancel the cycle or else start antagonist. After starting antagonist, I change over to HMG. The SCG trigger to be given 5000 international unit, luteal support in the form of progesterone. But what has been observed is 15% of the patients are not suitable for CC plus fixed FSH protocol. Rest 85% are fit for this protocol, and which gives good oocyte quality and pregnancy rate. What has been observed? The clinical pregnancy rate per embryo transfer and implantation rate were 35% and 23.5% respectively in fresh cycle and 32 and 27% respectively in frozen cycle. So almost same equal results in fresh cycles also. The highest pregnancy and implantation rates were observed in the first and second cycle compared with the third one, which confirms that patients who were most likely to get pregnant were able to achieve pregnancy in a short period. Remarkably, after 3 consecutive transfers, the cumulative live birth rate per patient was 70%, which is quite good. And stimulation cost is also remarkably less in this cycle. Now, how many cycle IVF to be offered to the patient? The highest success is in first 3 cycles, less in fourth cycle. If 4 to 5 cycles of the IVF are failed, donor eggs or sperms are suggested for getting the good results. Many times in poor responder, stop agonist protocol is used, in which the luprolide 0.5 milligram subcutaneous from mid-luteal phase is used from the previous month and stopped with the onset of the menses, with the hoping that it prevents too much ovarian suppression. But there are some studies which showed that after stopping the agonist stop protocol, the E2 level fell down. So probably in some of the patient it doesn't work. There is one largest the prospective randomized control trial which compared the mild stimulation protocol with the long protocol for the poor responder. And what they found that the mild CC gonadotropin GnRH antagonist protocol allows obtaining IVF results similar to those of classical long protocol with a high dose of exogenous gonadotropin. Indeed, the long protocol lowers the risk of cycle cancellation and allows retrieving more oocytes and producing more embryos, but ultimately does not provide increased clinical pregnancy and ongoing pregnancy rate. While showing a similar success rate, the mild protocol is probably cheaper as it requires much less exogenous gonadotropin, whose cost is one of the major expenditure in the human IVF. The result of the study suggests that according to the search of an optimal balance between effectiveness and cost, using a high dose gonadotropin protocol in expected poor responder may be questionable if not paralleled by a relative improvement in the clinical outcome. There is another protocol which is a luteal stimulation protocol. This protocol is not ideal for anovulatory infertility. After documenting the ovulation, within 3 days, the follicles post ovulation should be less than 8 millimeter. After that, HMG 225 plus letrozole 2.5 milligram daily is started. The letrozole is stopped when the lead follicle reaches 12 millimeter. The Maprate 10 milligram is added to postpone the menses so that it doesn't interfere in ovum pickup if day 12 post ovulation follicle is less than 14 millimeter. Trigger agonist at least 20 millimeter and 18 millimeter follicles are present. The ovum pickup ICSI, day 3 vitrification for all, and transfer in the subsequent cycle. The luteal stimulation protocol is thought after confirmation that there is a constant recruitment of the follicles all throughout the cycle, provided they are stimulated with the gonadotropin. So, all throughout the cycle during follicular phase, luteal phase, there are recruitable follicles present in the ovary. If they are stimulated, they start growing and it gives a good result. Because it has been clearly proved that the progesterone, presence of progesterone, fluctuating progesterone, not tonically high progesterone, doesn't affect the oocyte quality. It affects the endometrial receptivity, and that is the reason we are freezing all the embryos to transfer later on. Other protocols we will discuss the next time. Thank you.